Hello, everyone. My name's Corey Adams, and I'm a clinical researcher at the Australian Institute of Health Innovation, which is based in Sydney, Australia. So, unfortunately, I can't be with you at the event this year. However, I'm still really pleased that we have this opportunity to present the results of our recent research on the important topic of enhancing inclusion in patient experience measurement. I hope you enjoy the presentation. So first of all, I'd like to start by acknowledging the traditional custodians of the land on which we are all situated today, particularly the Wullumatagal people of the Durug Nation. We acknowledge the traditional custodians of the various lands on which we are all participating in today, and we pay our respects to elders past, present, and emerging. All right, so as I've mentioned, my name's Corey Adams. I'm really pleased to be joined in this presentation today by Professor Rima Harrison. Professor Harrison is the lead for the Healthcare Engagement and Equity Research stream at the Australian Institute of Health Innovation at Macquarie University. So there's a few learning objectives for this session today. Our focus will be on identifying opportunities to improve inclusion in patient experience measurement. We're going to start off by exploring differences in patient experiences for people from ethnic minority backgrounds. And sharing the results of some research that we conducted about that. Then we're also going to share the findings of two of the reviews that we conducted in evaluating the use of patient-reported experience measures for people from culturally and linguistically diverse backgrounds and those with an intellectual disability. And then finally, we're going to focus on some strategies to enhance inclusion and share an example of a project that we're currently undertaking to co-create PREMS for people with an intellectual disability, which is called Listen to Me. So as you can see here, the agenda for this presentation is split into four main parts. We're going to start by reviewing the key drivers of patient experience through some research that we conducted about the three pillars of patient experience. And then we're going to focus on different experiences of different patient cohorts. And then, as I mentioned, looking at the results of that review of PREMS, and then how we can co-create PREMS for people with disabilities. So I wanted to start this presentation by looking at this quote, which I think really summarizes the key messaging from this session today, which is that inclusion is intentional. It's about identifying and removing barriers so that everyone can participate to the best of their ability. And I think that really summarizes the goals of this session, which is we're presenting some of the research around what those barriers actually are, and also providing suggestions about ways that we can remove those barriers and ensure that everyone can participate to share their experiences of healthcare and to provide feedback to support improvement and quality and safety in healthcare. So first of all, when we look at the topic of measuring patient experience, as we probably all know, that there are significant resources that are spent to try and understand patient experiences and to collate data and to analyze, that data to gain insights. And whilst these insights might be useful to help guide improvements to enhance quality and safety and also equity of healthcare services, it's important to recognise that these measures do have limitations, and there's actually no universally accepted best practice method for measuring patient experience. So the goal of this presentation is to discuss what some of those limitations might be and how you can refine your approach to make sure that your methods are more inclusive for your diverse patient cohorts. Okay, so this is an article that we published recently, which looks at the key drivers of patient experience. So what we did is we analysed the patient feedback, which was the free text comments from the Net Promoter Score, and we thematically analysed this information to try and identify what are the key drivers of patient experience And was there any, common elements to patient experience amongst these patients? So this was conducted on 450 comments over a 6-month period. And the results from this research led to us developing a framework to better understand the key drivers of patient experience, which we call the 3 pillars of patient experience. So there were 3 key themes that emerged from the data. And these 3 main drivers of patient experience, as you can see, we've summarized here. So pillar 1 related to the provision of safe, timely, and effective treatment. And we're very specific in the wording that was used because this reflects the feedback that was provided by patients. So safety was obviously, a foundational requirement for patients, but they also wanted to ensure that the treatment was effective in doing things like, addressing pain or addressing their presenting symptoms, and that also the timeliness of that treatment was really important. But it's also important to recognize the importance of human interactions. And it was really highlighted, as you can see here in Pillar 2, the importance of interactions with clinicians. And some of the key descriptors were around staff being caring and attentive. So making sure that we're mindful about patients' needs and responding to those. And then finally, the third pillar was around environment. So the hospital environment, ensuring that it was comfortable and also healing and therapeutic for patients to support their recovery. All right. So it's important that whilst we've looked at the overall drivers of patient experience, that we recognize that in a lot of these situations, when we're measuring patient experience and looking at the results, we're actually looking at the average experience. But as we know that people's their personalities are different and people have unique expectations. And patient experience is really complex and subjective. And I really like this example here from a project over 10 years ago now, but it was called The Face of Tomorrow. And what they did was they identified the average faces. So these are the average faces of a male and a female in Bondi in Sydney. And as you can see here, they actually this was a composite image of many different people and their faces, and it really illustrates that when we look at the average experience, we might actually be masking and obscuring valuable insights about specific experiences of unique cohorts of patients. And so part of my research is really unpacking that and making sure we don't miss those valuable insights, which is what we'll be discussing today. So this leads us to the question, what are the differences in patient experiences among people from ethnic minority backgrounds? We recently published an article about this in the Journal of Patient Experience, in the edition about advancing equity and inclusion to improve healthcare experiences. And the results of this were from a study where we wanted to compare the experiences of people with limited English proficiency and those from ethnic minority backgrounds to what we've called general patients in the Australian healthcare setting. For this study, we used HCAHPS data, which was collected over a 5-year period. As you can see, there were responses from over 2,000 patients, and 490 of those patients identified as having limited English proficiency. So what did we find? So first of all, we found that there was actually a statistically significant difference between our cohorts of patients. And surprisingly, patients with limited English proficiency actually rated their experiences as being significantly higher in 3 areas. As you can see here, this was doctors listening carefully and explaining in a way that patients could understand. And they also rated higher for quietness at night. And conversely, patients also scored significantly lower in 2 areas, which were regarding nursing respect and responsiveness to call bells. And as we've discussed, although patients overall had a more positive experience, this was not statistically significant. Now, the key findings from this study were interesting for a few reasons, but First of all, it conflicts with other research that shows that there are people from culturally and linguistically diverse backgrounds often have poorer health outcomes, uh, which, as you can see, there was a misalignment there in terms of noting that people often had more positive experiences in hospital. As you can see, if you look at that paper, we've discussed some potential reasons for that, including the happy migrant effect, but it really highlighted that additional research is important to understand the unique experiences of people from ethnic minority backgrounds and how that might influence their perception of care. So this led to us conducting a review of patient experience measures in patients from ethnic minority backgrounds. And when we conducted our review, it's important to note that here in Australia, almost 50% of the Australian population have ethnically diverse backgrounds. So they have one or more parents who are born overseas. So this is particularly relevant for us here in the Australian context. And some of the questions that we asked were, are the PREM tools appropriate to measure patient experience for this cohort of patients? And also, what supports are needed to enable patients to engage in the completion of patient-reported experience measures? And again, taking into account that patients from culturally and linguistically diverse backgrounds often have higher rates of healthcare associated harm and preventable hospitalizations than the general patient population. And what we found was that in many cases, the PREMs may not be appropriate for patients from ethnic minority backgrounds. For example, they may contain complex language and phrasing. And there's also surveys when we look at our standardized surveying that had large numbers of questions that may be challenging for patients with limited English proficiency to complete. All right, so as part of our review, we included 97 studies and 4 key themes were identified. So the first key theme that emerged was about strategies for identifying and recruiting ethnically diverse communities. So we noted that many studies had a targeted recruitment approach for people from ethnic minority backgrounds, such as purposeful sampling and snowball sampling. Some examples here were that people spoke with community groups and they sent flyers, and they also gained support with community leaders. Another important factor in the effectiveness of this measurement was bicultural workers who could support uh, patients in terms of explaining, the purpose of the research and encouraging participation. And that many projects also develop translated resources to support that recruitment. And the second theme involved the creation of data collection instruments and processes. So quite a few studies had used surveys that were translated into multiple languages, and there's a bit of a mixture in terms of whether they used existing PREM tools, which were validated, or whether they did some more localized surveying and created their own surveys and piloted those. Some of those were shorter versions of existing surveys. Uh, in terms of response rates, it was also noted that there were higher response rates if surveys were completed on site. And again, this may relate to that targeted recruitment approach that we talked about. But it was also important to consider conducting interviews in alignment with people's preferences, such as the language, their preferred language, and also the location, and also whether they wanted support people being present to assist, such as family members. Okay, so the third theme that emerged was about that there were specific topics of relevance for people from ethnically diverse communities. And so it was noted that these were particularly important in relation to their experiences in healthcare, issues such as healthcare navigation and access. So some people may have had a lack of knowledge for how to access healthcare systems such as primary and outpatient care. Cultural competence was also important. There are some studies regarding cancer and maternity care, And there's obviously some important considerations regarding cultural and religious beliefs for those patients. And again, patient-provider communication was really important, particularly with regards to access to interpreters. And finally, respectful interactions was key as well. As you may recall, respect came up in our research as well with nursing staff. But respectful interactions was really important for this patient cohort, such as making sure that their family were included in decision making. And finally, there was some discussion about the applications of this data and insights to guide improvements. And there was some mention about creating educational materials and staff training to support cultural safety and respectful behaviours. Okay, so following the review that we conducted in terms of PREMS for patients from ethnic minority backgrounds, we also conducted a rapid review looking at the effectiveness and suitability and strategies for measuring patient experience in patients with an intellectual disability. So our focus, as discussed, was people with an intellectual disability, which affects 1 to 3% of the population globally. And similar to those from an ethnic minority background, people with an intellectual disability also experience poorer health outcomes, including higher rates of healthcare associated harm and also higher rates of readmission to hospital. And also similarly, we also found that a lot of the standardized and generalized PREMs that are currently being used are not necessarily well suited for people with intellectual disabilities. As we discussed before, a lot of these have a large number of questions, which might be useful in terms of gathering a large amount of information about experiences, but this can cause a barrier to people with intellectual disabilities being able to participate. There's also some complexity regarding the information collection and things like a lack of images to help communicate uh, about the survey. And as discussed here, one of the quotes from our article was that the lack of suitable data collection tools and methods means that experiences of people with intellectual disability are excluded from system-wide data sets and cannot be used to inform systemic approaches to improve care. So this really highlights the importance of this issue and the need that we address this to try and minimize those barriers and enhance inclusion for people with disabilities, including those with intellectual disability. All right, so an overview about our research. Again, you can see the aims here. We looked at 48 documents. 26 of these were peer-reviewed journal articles. So interestingly, one of the key findings was even though we identified instances of surveys specifically for people with disabilities, often these were used in an aggregated way so that the surveys encompassed basically people with all disabilities, including physical and intellectual disabilities. So there wasn't necessarily a consideration to the differences in abilities and how the surveys may need to be tailored and adjusted. However, we also identified strategies to improve the collection of data and the ability for people to participate and be supported in that data collection process. And this really centered about increasing choice and accommodating personal preferences for data collection. Some examples are listed here, including considering the location. So where would the person like the data collection to occur? So if it's an interview, would they feel more comfortable being interviewed in their home, for example? Another one is about the choice of who's there as well. Would they like a support person, such as a family member or a carer, or maybe there's a staff member that they're familiar with that can support with that data collection? Also, flexibility is really key. So, understanding that while we might use surveying and quantitative methods of data collection, which can be useful for standardizing and comparing scores, if we really want to gain information about experiences, we need to be flexible with our methods of data collection. So in some instances, qualitative methods might be more useful. If we are using surveys, making sure that these use plain language, and also giving people the option, if they're doing something like an interview, to break up the interview as well. So again, being flexible, being accommodating, and not trying to be too rigid in that data collection will probably help in terms of gaining more information that can be more useful and actually more insightful about people's experiences. And finally, in terms of the implications, it was also noted that it was really important to complement the information gathered from patients with an intellectual disability with the experience of their family members and carers. So understanding that in many instances, the family members and carers have a lot of valuable insights. They're with these people for a long period of time during their hospitalisation and can also observe the interactions with the clinicians and understanding of the outcomes and the quality of the care that's provided. As we've discussed in our previous review, we also identified that there were specific topics that appeared to be particularly relevant to people with an intellectual disability. So some of these topics included the care transitions, the duration of appointments and wait times, and interactions between staff and support persons such as family members. And also the need for people to be supported to gain independence was critical as well. As we discussed with the three pillars of patient experience, one of the highlighted areas was about the hospital environment. And in this case, however, it's more than just about comfort. It was really emphasized as being important due to key factors such as excessive noise, stimulation, and long wait times were particularly important for people with an intellectual disability. So again, whilst we can look at things in terms of a generalized topic like the environment, it's important to ensure that we take a more of a closer examination for what that actually means for different patient cohorts. And there's also actually little research available about how patient-reported experience measures are being used to support healthcare service improvement. And we probably see that in general in terms of there's little information out there in terms of how we're using this data from patient experience, more than just using it for evaluation, but using it to guide improvements. So from the review, we identified that there's really a gap in this area, which presents an opportunity to co-create patient-reported experience measures and tools for people with intellectual disabilities. And this leads to the final part of our presentation today, which is going to outline the project that we're currently working on, which is called Listen to Me. And I'm going to hand over now to Professor Rima Harrison to talk through that with you.
Thanks, Corey, and it's wonderful to have the opportunity to join this presentation. So I'm Rima Harrison from the Australian Institute of Health Innovation, where I'm a Professor in Health Systems and Safety Research, and I'm going to tell you a bit more about a project that we've been working on for the past year or so, but has been in our minds and has been in development for many years before that. And that project's called Listen to Me, and it's about co-creating patient-reported experience measures for people with intellectual disability. So Listen to Me is a little bit different because it's a project that was developed from the idea of people with intellectual disability who have been using healthcare services and finding that they were having poor experiences of care. In 2018, we established a collaboration between those consumers, along with some health professionals and some academics, to try to understand what we could do to try to improve care, not only for those individuals, but more broadly across the Australian health system. And so we initially were successful with a seed funding grant, and it gave us 12 months to be able to figure out how we could work together to do research. So we learned how to do research together, some methods that might work to help us communicate, and through that we developed a protocol for a larger project that would be about developing a patient-reported experience measure that was suitable for people with intellectual disability to be able to provide their own experiences of care directly to the health services. And so we then sought funding from a national scheme. So you can see there something called the MRFF Consumer-Led Research. That's a 3-year national funding programme by the Medical Research Future Fund in Australia. And that supported us to build upon the work that we'd started and to design a programme of research that was going to be about building this PREM, but also being able to design something that's going to be suitable for people with a range of different abilities. So over the last year, we've really been focusing on the co-design approach, and we've been working with a large number of stakeholders across the Australian health system. You can see their names listed here. This includes healthcare organisations who are providing care directly, who are in charge of designing health systems, who are responsible for collecting and using patient-reported experience data, and also organisations that represent and support consumers to be involved in their care. And that's in addition to a number of university partners. The most important thing about the Listen to Me project is that it's driven and led by lived experience researchers. And so I mentioned that we collaborated early on from about 2018, and this was a group of people that we started our collaboration with. So Matthew Van Hoek, his mother Debbie Van Hoek, Maya Tokitaki, her mother Karen Phillips, Kim Bowen, Pandora Patterson, Elizabeth Manius and Dalal Dawood. And these are individuals who either have intellectual disability themselves or are caring for somebody on a regular basis who has a significant intellectual disability that impacts on their communication and interaction in the health system. And so this has been really different and really important in being able to design a PREM from the perspective of the people who are going to be using this tool rather than the perspective of the health system. And so we've been thinking about how to do co-design with patients and people who are carers to be able to develop the instrument, but also what matters to them in terms of what's collected in that instrument and how it's then used in practice. And over the course of this research, this group is collaborating with university and clinician partners to be able to not only design and develop a digital PREM, but also to actually apply that in more than 20 hospitals across Australia and be able to apply that in quality improvement projects so that we start to not only gather patient experience data, but actually use it for improvement. So we're just at the start of our journey. Although we've been together for a long time trying to put this work together, we're actually just coming towards the end of the co-design of the actual PREM. So I'll tell you a bit about where we are so far in the early findings and hope that in the future we'll be able to come back with the full tool and be able to present that to this audience as well. So our co-design approach has really built upon the methods that we learnt back in 2018 and 2019 when we got that seed funding to start working together. We've used things like body mapping and art-based methods to be able to communicate between us as a group and to be able to look at the existing information out there that Corey's really nicely summarised for us around PREMs that have been used or developed with people with intellectual disability, and to create something that's really suitable for widespread use across the Australian health system and potentially beyond that into health systems internationally. And so we have really reached the end of our phase 1 and phase 2 stage, and we're just about to start user testing with an early prototype. And that user testing is going to help us to understand how this tool can be used by people with a range of different abilities and a range of different experiences in the health system, so that we can try to make something that is inclusive as possible for when we go out into the hospital environment and start to pilot this instrument. So what have we found so far? I mean, we've learned a lot about how to do design work together, but I think we've also learned a lot about the kinds of things that are naturally a part of PREMs that have been used in the general population that are not necessarily issues that are going to directly transfer and work well when trying to collect patient experience data among people with intellectual disability. So often in PREMs we ask people about past events. We ask them about when they were in hospital a week or two ago, and that can be really challenging when you're trying to cast your mind back as a person with intellectual disability to a particular point in time. And we've found that most people would prefer to be asked in the moment or immediately after something has happened about that particular experience, rather than being asked to cast their minds back to a different time. We also identified, as mentioned in Corey's piece earlier, that there are a number of important topics that do matter for people with intellectual disability, but actually the topics that matter to patients and to their carers might be a little bit different, and the topics that matter generally across the population in terms of improving healthcare quality, and the questions that people have in the moment that they want to ask of healthcare services also vary quite broadly. And so perhaps having a useful prem is having an opportunity for people to ask the questions that they want to ask. And it's more about whether that has been done than whether they were provided information about particular said topics, because those are going to vary between different people. Another thing that's unsurprising but worth noting is there needs to be flexibility in the implementation options. So when and how the survey is actually delivered to people, there's often the need to have quite some degree of conversation with support persons, with staff, when identifying people with intellectual disability and preparing for that communication appropriately. And then when actually in the process of completing a prem, we've identified a need to include audio, touch, visual and motion responses within our prem to enable a wide range of people to directly report their experiences. And so we're hoping that we're going to have address these issues within our preliminary prem, but we know there's going to be a long way to go from the prototype to something that's working for a lot of people. So our next steps for this study are to undertake some preliminary testing, as mentioned, and so we're going to start off by working with 20 people with different kinds of intellectual disability and different ways in which that impacts their communication with healthcare services. And we're going to gather some information from those individuals and their supporters about how to improve this tool so that it can be used by as many people as possible. We're then going to refine the prototype that we have. I'm going to pilot that in 20 hospitals across Australia, and we're seeking to achieve a target sample size of at least 700 or more adults and almost 600 children to be able to have a look at what patient experiences look like across hospitals nationally, and also understand how those experiences might relate to outcomes by comparing our prems with linked data that's available to us around healthcare outcomes in hospital among people with intellectual disability. And so this project will go on for another 2 years now, and we look forward to reporting further findings in due course. Thanks for the opportunity to present this work today. So to conclude this session today, we really want to highlight the importance of having inclusive prems in order to be able to identify the experiences of people who have high healthcare utilisation and often have poorer outcomes. By using prems effectively and actually applying them for action, we'll be able to understand and better improve quality of care among these population groups. That's something that we are moving towards, but we're not yet there. We know that there's several strategies available to be able to make prems more inclusive, whether that be in the actual tool itself or in the way that it's implemented with populations, but that those strategies are not necessarily used in a routine way across health systems or multiple organisations and networks. And we've also identified the importance of collaboration with the target population to determine how a patient experience measure might best be used in their particular context. So it's not just a matter of taking a general population measure and then translating it or making it into an easy read version. That may go some way to making it more accessible, but it's not necessarily providing the information that patients want to provide about their care. And so that collaboration is really important in actually creating these measures together and making sure that they're really hitting the mark. Thank you so much for your time today and listening to our various pieces of work around patient experience measurement and inclusive approaches. If you'd like to know more or get in touch about work that you're involved with at the moment or planning to do, I'm happy to have some correspondence via email or via X using the information provided there, and also Corey's information provided there. Our team work around healthcare engagement and equity research, and we have a number of projects in this space, and we look forward to discussing these further. Thank you.